for the record.
Thank you.
Thank you. Senator Marshall.
Well, thank you, Chairwoman. Dr. Califf, welcome, and again, thanks for visiting with me one-on-one, and we appreciate your willingness to put your life out here in front of all of us. Ranking Member, my good friend Senator Burr spoke a little bit earlier about real-world evidence. June of this year, I thought there was enough evidence for boosters that as a prescribing physician myself, I would have recommended it, and I did recommend it for my parents and for senior citizens and probably people with health care risk. So in June, I thought there was enough real-world evidence, but it was fall by the time the FDA moved on it, and really November before my parents were able to get it. I saw the Delta wave coming, and if we could have got those boosters in senior citizens' arms this summer, we would have saved tens and thousands of lives. How can we move more quickly with real-world evidence with a drug, a vaccine that's already had FDA clearance, but just a new use?
Well, let's dream a little bit, but I don't think the dream is far away if we get the human aspects of this right. There is no technological limitation now to having immediate access to all of the transactions that are occurring in our health system, the treatments that people get, the conditions that they're diagnosed with, and their outcomes. But we have a labyrinth of information that needs to be knitted together to make that happen so that we have information in as close to real time as possible. You've seen an approximation of this with the COVID tracker that we all look at every day that shows us almost in real time the number of cases, the hospitalization rates, and the death rates. And so it's very much, if I'm confirmed, part of my agenda to get the rules in place, the systems in place, as I have discussed, to give people confidence that it actually is in their interest to share data. But for that to work, we got to have those rules right, and those who misuse people's information need to be severely punished.
Okay, thank you. If I think about the last 20, 30, 40 greatest miracle drugs that have come to fruition in this world, maybe all of them have a relationship to the United States. What would the international price index, if that was instituted in this country, or a Medicare price negotiation, any type of price fixing by the government, what would that do to innovation in our world of drugs?
Well, Senator Marshall, I'm not sure we'll completely agree on this one, but let me just say that I do think that there needs to be, wealthy countries need to share in the cost and in paying their fair share for drugs. I'm sure you agree with that. And so, you know, in any kind of negotiation that occurs, if we go too far, it will squelch innovation, but we've got to find a sweet spot, which I would argue is a little bit off right now, because I'm acutely aware that, for example, almost a quarter of cancer patients end up not following through on the chemotherapy because they don't have the financial means to pay for these effective drugs. And people think of cardiology, my specialty, as sort of nuts and bolts, bread and butter, but it turns out financial toxicity is now a significant issue for patients with cardiovascular disease. So I do think we need an adjustment to find a sweet spot, but I also think other countries need to pay their fair share.
Thank you. RU-486 is a drug I've never prescribed as an obstetrician gynecologist, but unfortunately I've had to take care of patients with complications from it, typically in the emergency room. These patients not only have physical complications, hemorrhaging and bleeding, but certain psychological challenges after they've had that abortion, this kind of remorse afterwards. And I'm very troubled by HHS's casual attitude about prescribing RU-486. Are you committed that that should be in the hands of physicians and prescribers and not handed out like candy?
Well, as we've already discussed, I think the FDA has to make its decision based on the latest data and the scientific principles. And as we've already discussed also, I know more information is soon to become available. I'm not involved in those discussions, but I do trust the FDA staff to make good decisions.
Okay. I guess I got time for one more. I was frustrated last year that the FDA moved really quickly on some testing for coronavirus, but not on T-cell testing. As a clinician, I just want to have the choice, the ability. I don't want the FDA to decide for me whether I should use the T-cell. I just want to, if it's safe, it's available. What can you do to make sure that the FDA going forward is not choosing winners and losers? And why wouldn't you prioritize the T-cell every bit as much as some of the other testing? It just felt like that became a political turmoil rather than trying to do what's best and letting clinicians decide.
You know, when I came along in the 1970s, cardiology was really exciting, and immunology was this evolving field. It was just amazingly complicated. It was really hard to understand. We've come a long way, and there's no question that T cells, I mean, if we think about it, the B cells now protect us from the acute infection, particularly in the nasopharynx with the pandemic. The T cells that's what's called into effect in the long term to prevent death and hospitalization. So I'm totally with you that we need to have T-cell testing, but it's also, without going, you know, into laborious detail, and it's not my area of expertise, I'm just say that it's complicated because just measuring something in the blood of someone doesn't give us the information we need, because the T-cells have a memory, and when they get the right stimulus, they swing into action and create an army of T-cells to come in and do the job. So I would just say, I know the FDA is interested in this. I personally think it's a critical issue that we need to continue to work on, but we have to have reliable tests that give us the information we need, and maybe the combination of evolving tests and the real-world evidence that we've talked about will give us the information that we need.
Thank you so much. I yield back.
Senator Lujan.
Thank you, Chair Murray. Doctor, we've seen a new record high of opioid deaths